Thank you everyone for joining us today. This presentation is going to be on diabetes with a lot of emphasis on insulin. Last year when I spoke to the home health agencies, the topic was on drug interactions, medication interactions, with a large focus on anticoagulation, because I sit on the Sentinel Event Task Force for Healthy at Home. And we find some of our discussions have these recurring themes. Anticoagulation was one of those themes where we had a number of unfortunate events leading to patient harm. During several recent Sentinel events, we began to see another theme where insulin once again was constantly contributing to or somewhat contributing to patient harm. So I was asked to present on insulin, but I'm going to take it a little further than that. Because see, how many nurses do I have in the room? Show of hands. All right, excellent. Therapists? Excellent. Because what I'm going to be sharing with you will specifically, address both what professions do in the home, and I want you to have a better understanding on what's going on with the patient holistically, not just the insulin, because I want you to be able to better educate that patient. How many folks in the audience actually have diabetes that we have, all right, or know somebody, all right? I want you to be aware of what's going on, because there's a lot of confusion sometimes about what diabetes is and why and how we do what we do. I'll speak a little more about the Sentinel event that occurred as we get into insulin. I have to emphasize, diabetes is a metabolic disorder. This isn't just sugar, 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 because we talk about it all the time. Glucose, 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 right? This is bigger than that. This is a metabolic dysfunction that we have in which the body is not working properly. We've got an epidemic of diabetes in this country right now. 24 million patients have diabetes, 57 have prediabetes. You may not know what that really means. How many of you people actually know what prediabetes means, right? We're going to talk about that in a minute. 90% of all the diabetics are type 2. Why? Interesting. We'll talk about that as well. Risk factors, family history, obesity being greater than 20% ideal body weight, which goes hand in hand, my therapist will tell us, it goes hand in hand. Decreased physical exercise, obesity, decreased physical exercise. They go hand in hand. It's a problem. Smoking is an issue. Holy moly. Diet is obviously a major contributing problem. In the United States, again, of all the diabetics we have, 7 to 10% of those are insulin dependent. Now here's an interesting thing. Again, I can't overemphasize this. Because this is a metabolic disorder, the vascular system is the #1 problem. Of the 20,000 amputations that take place every year, half of those are related to patients with diabetes. Think about that. Why? What's the connection between sugar, sugar, sugar and amputations? When we talk about diabetics, there's 2 classifications: patients who are resistant to insulin and those who simply have insufficient insulin, and sometimes it's a blend of both. So let's go back in time, days of school, days of physiology. If we're going to talk about diabetes, that means something's broken. So to understand what's broken, we got to understand what is normal. That's what we're going to talk about first. So what happens, right? What's going on with diabetes? When we eat, and this is the human body, okay? This is your stomach, right? And then it goes into the bloodstream. This is the bloodstream. So when you eat food, it's absorbed and comes into the bloodstream. And you get glucose that comes into the bloodstream. In the presence of glucose, the body produces, from the pancreas, insulin. Insulin comes over here, and what does insulin do? What's the primary role of insulin? This is muscle. This is cell. Let me redraw that, because I'm going to be emphasizing this. This is a cell. So what's the job of insulin? Anybody?
Produce energy.
Produce energy? Not quite.
Facilitate glucose into the cell.
All right, excellent, right? That's one of the things glucose does. It takes this glucose and puts it in the right place, takes it out of the blood, puts it in the muscle, puts it in the cell. That's its role. What else does it do? So that's the same reaction I get from my pharmacy students. I teach pharmacy students. That's the same answer I get. What do you mean, what else does it do? Well, guess what? Not only is glucose absorbed in here, but protein. It gets sent in here. Free fatty acids, lipids, right? Fat. It also is taken and put into the muscle. Yes, insulin is an anabolic hormone, the most potent anabolic hormone we have in the human body, which means it's all about growth. It's all about taking this stuff and putting it in its right place. This is what normally happens. When insulin comes along, there's actually, and we'll talk about this too, when insulin is produced, when it touches this cell, it's looking for, it's a key looking for a keyhole. And interestingly enough, that's kind of what that receptor looks like. So when insulin hits that cell, boom, all this stuff comes into the cell. That's the primary role of insulin, to take everything out of the blood and put it into the tissue so the tissue can grow and build and repair. Now, fascinating thing here. In the body, there's a thing called the pancreas. Everybody knows about insulin in the pancreas. But most of us forget there's another thing called glucagon. This is the other hormone that the pancreas produces. And these two work hand in hand. So guess what? Not only does insulin take this and put it in the muscle, there's this marvelous organ, one of my favorites, the liver. And it takes that glucose and it puts it in the liver and it stores it as glycogen. Now this is important because this is literally like an ATM machine for the body. The brain is like a 2-year-old. Feed me, feed me, feed me, feed me, feed me. And what does it want to eat? Sugar, right? Just like a 2-year-old, right? Sugar, 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 sugar. I'm happy when you're feeding me sugar, right? So, this is what happens. We had breakfast this morning, right? Let's say we ate breakfast at 6 a.m. It's in the bloodstream. Insulin's produced. It takes the fat, the protein, the glucose, puts it in the muscle, and most of the glucose is actually going to be put into the liver. Oh my, it's now 9 o'clock, 9:30. Starting to get that little rumble, right? Starting to get that little headache. What's happening? The brain is saying, feed me, feed me, feed me. So what does it do? It simply sends a signal to the liver and says, hey, I want to cash in on some of my glucose. So the pancreas is going to send glucagon to take this glycogen and do what? Convert it back to glucose and put it in the blood, so now the brain is happy. This is how insulin and glucagon work together. This takes it out of the tissues, puts it in the blood to feed the brain. Insulin puts everything inside. Now, interesting fact, the brain doesn't require insulin, nor does the GI tract. All it wants is sugar. Just feed me sugar. So after fasting, now this is what Atkins discovered. This is the reason when we shift our intake. Dr. Atkins promoted what? Low carbohydrates, higher fat, higher protein, right? Why? Because the number one stimulation of insulin is the presence of glucose. What Atkins discovered, if we shift our intake to be predominantly fat and protein, it doesn't produce as much insulin. So what? Well, you see, when you begin to have that hunger headache, that little throbbing in the back of your brain, what's actually occurring is that those fat stores, as the insulin goes away, it's done its job. The brain is now hungry. Glycogen's going to do its best to feed the brain, but what else is going to happen? Those stores of fat over here also begin to release. And it releases in a form called beta-hydroxybutyric acid. Now, I emphasize acid because we're going to talk about that with DKA. But it breaks down triglycerides back into the blood. That's how it helps feed the brain. Now, the brain, it's like, ooh, man, I don't like it. I'll eat it, but I just don't like it, right? It's like green beans for a 2-year-old. But it will eat it. This is another fuel source. So all of a sudden, when you're fasting, those vault doors of fat begin to crack open, and you're now actually burning fat. It's coming into the tissue, and this is actually getting smaller. Hooray, we're losing weight. But guess what happens around 10 o'clock? I'm hungry. I'm going to get me a snack. So I'll go get me a soda and crackers, and guess what? Glucose comes in here, insulin comes back to do its job, and guess what? Those vault doors go boom. They slam shut. And all this fat stays right here, and glucose feeds the brain, and nothing comes out of here. This is a normal process of how insulin works, glucagon works. They work in balance. So when we talk about diabetes, we've got an abnormality. So let's talk about diabetes a little bit. I am no artist, but I do love to draw, by the way. When we have type 1 diabetes, this is how I teach my students how to remember this, right? Type 1 looks like an I for insulin, so you never forget. Type 1 requires insulin, so now you'll never forget it. Type 1, obviously, you have to replace the insulin. Type 2, insulin is produced, but it's not functioning properly at the cellular level. Now, the good news is, from a side effect standpoint for the nurses out in the field, rarely do we see diabetic ketoacidosis because a little bit of insulin will help prevent that even in a type 2 diabetic. Let's talk about type 1, the lack of insulin. So what's going on here? People don't die from diabetes because they have an elevated blood sugar, right? We got people walking around with 400, 600 glucose levels all the time, right? They don't just die. So what do they die of? What's the problem? What's going on? They die from complications of vascular disease. See, insulin is the hormone that properly takes everything, builds it, stores it in the cells. So when we don't have insulin, we've got a complication. When we talk about fat, right? Here's fat. This is the blood vessel, right? When we talk about insulin, right, and the lack of insulin, fat is going to start fueling this with triglycerides, which is free fatty acids, right, into the blood, including cholesterol. What's happening here when we have lack of insulin is this phenomenon called glycation. So when you eat and you start putting glucose into the blood and there's no insulin to come to the rescue, then this glucose and the proteins in here form this goo. It's called glycation. That's the problem. This glucose never gets produced and then put over here into the muscle or into the cell. It's broken. It can't move properly. So where does this goo go, this glycation? Well, it begins to settle down into the tissue of the blood vessel. Now again, we're going to go back in time in school at our days of anatomy. You got to remember red blood cells, right? When they go, all right, let me do this. This is your vascular system. Arteries arterioles, capillaries, venules, veins. And this is your heart, okay? This is your circulatory system. Remember, arteries are big, they get smaller arterioles, and then we get to the capillaries. And the capillaries are so small, so thin, that red blood cells actually line up one by one to go through the capillaries. And remember, this epithelial tissue is so thin, it's only one epithelial cell thick. That's how tiny this is. It's very delicate. Glycation occurs when insulin is not able to process all this stuff that's in the blood. So now you get this goo that begins to settle and damage along this wall. This is the reason we talk about microvascular disease. Micro simply means the small blood vessels. This is where blindness comes in. This is where hemodialysis comes in because of renal failure. This is where strokes come into play. Heart attacks come into play, right? Where do we have capillaries that are important in the body? Everywhere, right? Those important organs called the brain, the liver, right? So imagine this goo beginning to settle along that level. We talk about glycation. You hear the term hemoglobin A1C, right? Everybody know that term? What does it mean? Why do we measure it? I don't know, it's just a number. Doc, the number, hemoglobin A1C is such and such. Okay, then do this and this. Okay. What just happened? See, when we talk about glycation, we talk about this goo that's being formed. It's not just here in the blood vessels, right? It's also, we've discovered over the years, this goo also begins to affect the red blood cells, the hemoglobin in the blood. So when we talk about hemoglobin A1C, we're actually looking at the glycation effect that's occurring actually in the hemoglobin protein here in the red blood cells. Red blood cells have a lifetime of what? 3 months, 120 days, something like that, right? That's the reason if you check hemoglobin A1C, it's about every 3 months we're looking at this. So what does it tell us? Well, Mr. Smith goes to the doctor, and the doctor says, how you doing on your glucose control, Mr. Smith? Oh, I'm doing great. Oh, well, let's find out. Oh, according to your A1C level, that ain't the case. You are not controlling your glucose. And what does this tell us? Because, see, when that glucose level keeps going up in the blood, the glycation begins to build up in the red blood cells. They can't hide. All the way around the circulatory system, as that glucose and that goo is being passed around, all these red blood cells are being affected. So the more times you've got elevated blood sugar, the more times this goo is filling into those red blood cells. That's the reason, Angie, when you go to the doctor, he can tell, uh-oh, you are off your diet. Exactly. You've been no-no. Exactly. This is what prediabetes is all about. Because if you were to go to your doctor, who knows what a good A1C is? Right?
6 or less. Well, it depends on whether you're healthy or
Correct.
diabetic.
You want to be below that. But if you're not yet symptomatic and you go to the doctor and they test you for this and you're running up here around the 5.5s or 6, what does that mean? That means your insulin production is not sufficient enough to get rid of this goo that's spreading around here and here. Insulin is the key to pull it all out, to put it in its proper place. So with lack of insulin, you're on the verge of being symptomatic as a diabetic. That's what prediabetes is all about. Again, we talk about microvascular disease. It's simply the small vessels throughout the body. Here's a fascinating thing. Diabetic foot, for my therapist in the room. Not only are the blood vessels affected, right, in the eyes, but nerve endings, the intrinsic muscle, I like this, the intrinsic muscle of the foot is actually damaged through this process. Now, what's one of our major concerns of patients in the home? Falling. So now you get a patient with diabetes. The nerves are also impacted because, you've got these capillaries running through here, and they feed the nerve endings. So there's damage to feeding the nerve endings. So now you get people who have intrinsic muscle in the bottom of their feet doesn't work right. They've got neuropathy because damage to the nerve endings, so they can't feel the bottom of their feet. And they're obese. And they don't exercise much. And then they fall. Oh my. Do we have any of those patients in the home? Right? Every day. Why? Because these are the patients who need our help in the home. That's the reason we see so many of these patients. Macrovascular disease. Macro means the big muscles, right? The big vessels. Let's talk about that, because I want to emphasize this. All right, for my students in the room, we have arteries, we have veins. Anatomically, what's the difference between an artery and a vein? Anatomically,
One has valves and everyone doesn't.
that is true. Which one has valves? Why does it have valves?
Can return the blood.
Right? So the blood won't go backwards. Anatomically, though, the design of these, there's a difference. This bad boy, called the artery, has this thing called the intima around it. Intima is nothing but a muscle tissue. And what's its job? Elasticity. You see, the body has this beautiful way of knowing how to respond under stress. And the body knows how it's designed to get out of harm's way. So when a bear jumps out of the wood and starts chasing you, what do you want to happen? You want the heart rate to go up, you want the blood flow to pick up, and you want that son of a bitch to expand as big as it is, right? So the blood will just come rushing through you, right? You don't want to have to wait and say, let's see, it's going to start kicking in each time now. No, you're gone and you want it to respond. So what? Well, the so what comes in when we talk about hardening of the arteries. That's not a metaphor. That is a physical effect. See, in the blood, without insulin, right, what comes back in here? Fat, cholesterol, all this stuff. Because there's no place for it to go. Because without insulin, it just stays there and spins around and around and around. So what begins to happen in these arteries, right? You begin to get this stuff pulling. Now, this is free information. I won't charge you for this. Just so you know. Everybody likes to talk about, I went and had my cholesterol test today. Oh, and what was your HDL? And what was your LDL? As if we think we know what the hell we're talking about. HDL, LDL is not cholesterol, just so you know. That is not cholesterol. Cholesterol is actually a waxy substance, and it's required in the human body. Every cell membrane is made of cholesterol, by the way. But what happens when we get extra cholesterol in the blood, we have these little trucks. I call them dump trucks. And they're transport dump trucks. And they're taking cholesterol either hither or thither. Now, the reason we say one's good and one's bad is we've learned through research that the HDL truck, he drives it to the liver, and the liver will process it and eliminate it. However, your LDL driver is just a lazy, no-good driver. So he'll just be cruising along and he'll say, it's time for a nap. He'll take a nap, dump his load right there, right? There's his load of cholesterol. That's the difference. That's the reason we monitor HDL, LDL, because we want to know where these trucks are going. Because if we know where they're going, we got an idea if there's going to be a problem. So you get this junk plaque now building up inside your blood vessel in here, right? It starts getting smaller. And you've got glycation, goo. But what also happens? Here's the hardening part. Calcium is always in the blood, right? And where does this calcium begin to settle in? It begins to settle into this fatty tissue, and hence it becomes literally hardened. How many of you ever know what I'm talking about when I say a cheap garden hose from Kmart? That little green cheap garden hose, right? That's what's happening here. So when you try to wash your car with a cheap Kmart garden hose, you can't get that thing to uncurl sometimes. It's a crack, 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 crack. Well, that's what's happening here. This is macrovascular disease, and this is the number one cause of complications in diabetic patients. Because I'm telling you, all of a sudden, this doesn't work, this doesn't work. Let's see, could hypertension be a part of this picture as well? Oh, dude, yes. Why? Because the smaller this gets, the harder this has to pump. The harder this pumps, that's a whole nother story about congestive heart failure, but it creates intense pressure. The blood pressure goes up. The harder that works to push everything through this. So this is what's going on when I say a metabolic disorder with diabetes. It's not just what's your sugar level today. It's bigger than that. Because see, I want my folks in the home to help people understand. This is unfortunately a lifetime need of attention. And what I tell my students, there are times you're going to have to explain to that patient, you'll be lucky to wake up dead. You're not going to be that fortunate. You're going to suffer a stroke in the brain, heart attack. You're going to be bedbound. You're going to be unable to enjoy your grandkids and living life. That's the path you're on. You'll probably end up on hemodialysis. Because guess what? There's a thing down here called kidneys. And they're filled millions of these tiny little capillaries. That's how it works. So now you turn on the water spigot and the blood pressure is elevated and it comes busting through here, and guess what? It just breaks those capillaries. Oopsies. Don't worry, it'll heal itself. No, it won't. You're going to go on dialysis. I guarantee if you were to study dialysis patients, over 90% have diabetes and hypertension, because that's what blows these vessels right here. All right, insulin. Any questions on the physiology part? Because again, I want you to understand that, because as we talk about these, it's bigger than just glucose levels. Insulin. Some fun facts about insulin. Discovered in 1921, and since 2003, we no longer have it made from animal sources. You know, people used to say, well, I don't want that pork stuff in me, or bovine horse? It's all DNA. But here's what I want to emphasize to the clinicians in the room. We've got all types of insulin. Now I've just learned, who told me? Somebody here just told me. We now have a brand new FDA-approved ultra-short-acting insulin. Have anybody heard about this? It's like 15 seconds it starts to work. So we have rapid-acting, short-acting, intermediate-acting, long-acting, and of course combinations. Now, here we go. For my students in the room, we talk about the different types of insulin, and you commonly hear the term NPH. Who knows what NPH stands for? That's the same reaction I get from my students. NPH is neutral protamine Hagedorn. Who cares? Dr. Hagedorn discovered if you add this little protamine component to insulin, it can change its absorption. So when we give regular insulin, it has an effect as far as onset and duration. When we give NPH, it's different. Why? How do we normally give insulin? Insulin is administered where and what tissue? Sub-Q, right? Sub-Q tissue. How does the body know what to do with that insulin? Does it look at the label and say, oh, that's NPH, so I got to release it at this time and I'll last this time? No, how does the body know how to react? If I inject regular insulin or NPH into the same subcutaneous tissue, what's going to happen? Right? How does the body know? Well, let me put it this way. If I accidentally go a little too deep with my NPH injection and I hit a blood vessel, what's going to happen? That NPH will become what? Regular insulin. You see, the reason we put protamine in insulin is because inside the cell, insulin just can't come busting out. This is going to hang on to it, so it actually slows the release of the insulin out of the tissue into the blood. If it's just regular, boop, gone. That's the reason NPH is designed that way. I just emphasize that because if you don't administer it properly, it won't work properly. One of the number one problems we're seeing across the country right now, according to our resources that give us med-era information, insulin pens. How many of your patients use insulin injection pens? Right? All the time, most of them? Yeah. Right? It's becoming very, very popular. And what must you teach your patients about the use, proper use of an insulin pen? Y'all know what I'm talking about, an insulin pen? You know, back when I was in school, we only had things called needles and syringes and vials. We didn't have these fancy tools that we have today, right? So a pen is actually a preloaded cartridge, looks kind of like that, and you depress a button, stick it in, you depress a button, and what must you teach your patient about that?
Well, I usually teach them when they dial it up, and they put their needle on to check the amount again.
Excellent. And during the administration part, here's the subcutaneous tissue. When you put that needle in, you have to leave that needle in for at least 6 seconds. We recommend 10. Now think about this. Why? Why 10 seconds? Because that's how the damn thing works. It has nothing to do with the tissue, has nothing to do with anything else. That's how it works. It goes click, 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 click. It's working. The pen is actually working the insulin into the tissue. So you have to keep the needle in the tissue and count to 10. That's important. Because if you don't have the proper amount of insulin, you're not going to get the right response. So again, insulin pens, got to be very mindful of that. You too, okay? What else do we tell patients when we talk about insulin administration? Why? Excellent. Why? Scar tissue forms. Who cares? Right? This is your blood vessel, and if you keep poking that same spot over and over and over and over and over and over and over, what happens? You develop calluses essentially, right? So instead of you having all these different cells, you inject and it can just kind of work its way there, you've got scar tissue. You just got thick mess. So what happens when you put your insulin in there? It stays right there. You're injecting it into a callus, essentially. So rotate sites. It's very important. So when you're talking to your patients about insulin, help them understand this is important. All right. You'll know more about dosing of this stuff than I do. Insulin, I have to emphasize this, is one of the high alert medications. Why? Because it's dangerous. When I first gave this presentation, I gave it at Lincolnton. And I exaggerate not. Well, we're talking about some of the effects of insulin, hypoglycemia, and things of that nature. One of the nurses in the audience made a comment, murder by insulin. And there were some giggles in the audience. And it's like, well, you do have to be mindful that is a dangerous thing. Literally, 2 days later, I get this in my mailbox. And again, I share this because this is a very dangerous medication, and it can cause great harm in patients. But we're talking about the medication. So we got two components here. One is the disease that's not being properly treated, and one is the medication. So it is a very serious concern that we have. When we talk about insulin, we've got two issues. One, too little. One, too much. So what happens with too little? How many of you folks know the term diabetic ketoacidosis? This is, let's just say that's your blood vessel, okay? So when you have too little insulin, what's happening? You get glucose, you get fat, you get amino acids, and you get glucose, and you get glucose, and you get fat, right? And where does it go? Right? Well, like I said, I'm no artist. It goes round and round and round and round because there's no insulin to take it out of the blood and put it into the muscles and to the cells. So it just goes there. And guess what's down here? Things called kidneys. And all of a sudden, this stuff begins to overload the system. What's normal serum glucose? What do we like to keep our glucose level? Come on. 80 to 120, right? It's a good number.
Just depends on whether it's before
I
or
thought it
after.
changed to 70 to 110.
There's ranges. What's a normal range? What's a good range? 80 to 120, all right? Is a good range. This is normal in terms of if everything's working properly, the glucagon will come out of the pancreas and release the glycogen, right, to keep your blood sugar elevated so you don't bottom out and pass out on the floor. Insulin, if everything's working right, will come in and keep glucose below 120 because it takes it out of the vessel and puts it into the tissue if everything's working properly. But if you don't have enough insulin and this stuff begins to stockpile into the blood, then we got a problem. At what level do we begin to spill sugar, glucose into the urine? Come on. Now you got a problem. When this stuff builds up to 180, guess what? Now you got glucose being excreted in the urine. Who cares? When that glucose goes, how many of you folks drink Bojangles sweet tea? Right? What goes with that sugar? Water. So now all of a sudden, when you have lack of insulin, diabetic ketoacidosis begins to happen because dehydration is occurring because now you got polyuria. You're very thirsty because you can't keep up with it, polydipsia. And you've got this thing, remember, the fat is broken back into and feeds the brain with what? Beta hydroxybutyric acid. Now the brain's happy as it can be. It don't need insulin, it's got its stuff, I got lots of glucose. Brain's fine, brain care less. The kidneys on the other hand, are like, this sweet tea is a little sweet, baby. So all of a sudden, over about a 3-day course of time, you got severe dehydration, you have this buildup of acid, your pH changes, and now you got a real problem. Now you pass out. How many of you have actually seen a DKA event? Anybody? It's frightening. And what's the number one treatment, Barry, that we do with a DKA patient? As soon as you get them to the hospital, what's the first thing you give them? Nope. Insulin. Why? You want that stuff to get out of there. You work on the hydration piece after the fact. Because if you give them hydration, no insulin, all you're doing is just perpetuating. Insulin, get it out of there. So that's too little. Yeah, it takes about 3 days, right, to recover. It's awful. It's awful. All right, let's talk about the other side of the coin. Too much. Hypoglycemia, right? Now, one of the things I want to emphasize, let's go back to this. Here's a concern that I want you to be aware of. We talk about the normal here. Why? Why? Who's diabetics in the room, family of diabetics? What's a typical number? And don't say 120. What's a typical number of your diabetic family? 200, 300, 400 in a day? What? Give me a number. 250, right? Why are we targeting this? When I was doing my residency, yes, long time ago, back in the early 90s, there was a national study that was performed because researchers wanted to know how low is sufficient. Because see, when I was doing my residency, 200, we're happy. If you're below 200, you're good. That was our goal. And people were getting asked the question, is that really good enough? Oh no, I think so. We're not spilling as much sugar, right? We don't want to get crazy. Well, guess what? That research indicated, and this was tens of thousands of patients over a lot of years. And what do you think they found? That this glycation stuff is so severe, so dangerous, so life-threatening, long-term, that we have got to get this thing closer to here. That's the reason I sit on the nutrition committee at CMC, Atrium. And we've actually changed our goal. We want it to be 150 or less. Now, with that in mind, this is focused on this, the side effect component. But with that in mind, sometimes we get a little too zealous. Well, if 150 is good, 100 is even better. Well, if 100 is good, then 50 is even better. So I ain't going to have none of this stuff. So people get sloppy, or they get too aggressive, I should say. And they'll drive this thing too low. We don't want that. This is the complications of hypoglycemia. This is when the brain crashes, because there ain't nothing feeding it. It ain't happy. This is when you pass out. You've experienced it. You know exactly what I'm talking about. It's a frightening thing. When you've got patients, they begin to glaze over and fall over because they don't have sufficient glucose to keep the body working. Just be mindful. Okay? Yes, we want to be aggressive, but we don't want to overdo it. It's called over-insulinization. It's a great Scrabble word, by the way. It's hard to use in your daily vocabulary. It's hard to spell, too. All right? Signs and symptoms of hypoglycemia. You folks probably know that better than I do. But again, you get the brain's not happy, you get the tremors, right? How many of you have gone without eating for a while and you begin to have that sensation, I'm really struggling, right? Why? Because the body is just lacking. Now here's some contributing factors as well. Low body weight. Why? Because you don't have the reserves in the tissue to come support this. Long-acting insulin. Why? Because it's there and you can't get rid of it. It's still working. Insulin's still working. So sometimes when you overdo your long-acting insulin and you begin to not eat, the insulin's still going to be working. It's too late. The medications, the oral medications for diabetics, and renal failure. Why renal failure? What does that have to do with the price of tea of China? Why would renal failure, which is a common complication of diabetics, cause hypoglycemia? Because the liver and the kidneys are primarily responsible for the elimination of insulin. So if it can't eliminate it, insulin keeps spinning around and around, and it keeps working. Fever. Why fever? A lot of these patients are sick because it increases the metabolic activity. It's burning what glucose is in there, taking it away. There is an effect. I just want to share this with you because it's the Somogyi phenomenon. I just want to share it with you because sometimes people don't appreciate the influence of glucagon and its role, right? Because when we talk about some of the other medications, this is the pancreas, right? It produces insulin and it produces glucagon, right? Right? So if you give yourself insulin, too much insulin during the day, and you fall asleep at night, and your blood sugar begins to go down, how's the body going to respond? It perceives it as a threat. The brain sends signals, glucagon comes out, it's going to start squeezing all the glycogen from the liver back into the bloodstream. is coming to the rescue. It's going to do everything it can to pull glucose into the bloodstream. So when you wake up in the morning and you test your level, oh my, I have elevated glucose levels. I need more insulin. No, it's actually backwards. Some of these folks, because you're giving too much insulin during the day, they're actually bottoming out at night, and the body is trying to prevent you from dying while you sleep by producing glucagon, releasing glycogen, getting glucose back into the body. Just so you know. Again, signs and symptoms of hypoglycemia. The reason I want to emphasize this is because, see, and you need to know this. Our sentinel event that did occur, very unfortunate. We're very blessed that it did not directly affect one of our clinicians. However, what did occur, it was an elderly couple. He was on enteral feedings. He was also diabetic, receiving insulin. The nursing agent had gone out, talked to the patient, got him set up. Over a number of days, there was complications with the feeding tube, and the feeds were put on hold. But the wife, being dutiful, did what she's supposed to do. So she would keep giving him insulin. But there's no glucose for it to work on. And then after a couple days, he is unresponsive. They call 911. He's admitted, and unfortunately he passed away in the hospital. He never recovered from a diabetic coma that she unfortunately had induced. Now think about this. You're the caregiver. You're trying to save your loved one, and you end up being responsible for harming your loved one. So as we evaluated this information, it somewhat became apparent how good of a job are we doing educating these patients on the danger of this and the signs and symptoms to watch for. So we evaluated that, and guess what? We did a very poor job. So when we looked at how many folks have been discharged from the hospital, right? Seriously, or family, right? How many freaking stacks of pieces of paper do you get when you go home? Right? And what do you do with it? Right? And guess what? Buried in one of those little pieces of paper was, oh, by the way, be careful with your insulin because it might cause hypoglycemia and be dangerous. Literally, that's all we found. And that was from an RD's note in the hospital. When we reviewed what took place in the home, our nursing notes had very little, if any, about this. Because guess what? Oh, it's just insulin. Oh, it's just Coumadin. Oh, it's just another thing. No, it's not. So that's the reason this sentinel event took place, and that's the reason I'm sharing this with you today, because I cannot overemphasize. We have to make these patients aware. You don't take care of yourself, you're going to have this. You get too sloppy, you're going to have this. There is a real-life phenomenon. I need to emphasize this as well. I forget the exact term. When you just get so tired of monitoring, monitoring fatigue is what it's referred to. It's a real thing. Now, when Pam was going through her cancer, I know what they're talking about. Because guess what? Honey, what's your number today? Did you take your medicine? Yes, Mom. Honey, what's your number today? Did you take your medicine? Yes, Mom. Right? All day long. Tell me, right? Right? All day long. What's your number? What's your therapy? What's your number? What's your therapy? And guess what happens over the years? I'm tired. I do not care. Right? Give me a break, Mom. Right? Really? It's called monitoring fatigue. Again, when you go through a chronic illness, and unfortunately this can be a lifetime thing, you simply wear out. And I want to just remind our clinicians in the field, you've got to lift these folks up. Because I kid you not, if they don't, they're either going to have the complications here of macrovascular disease, or they get too aggressive, right? And they have issues with hypoglycemia. Because again, it's the start of the new year. And a lot of people say, you know what, I'm really going to start doing better. I'm going to lose weight. I'm going to start exercising. Well, make sure when you do that, you're corresponding your insulin with your glucose, right? Because if all of a sudden you stop eating glucose, but you still keep giving insulin because I'm going to be healthier and better, then you have problems. So again, be wise, be mindful. It is very dangerous. All right. I'm not going to make you students of all this stuff, but I do want to introduce the concept. Type 2. And the reason I want to emphasize this is because the majority of all the diabetics are type 2. It is an epidemic, and the number one contributing factor of type 2 diabetes is obesity. Why? Because, see, when insulin, remember we talked about insulin is the key. This is the key hole. When insulin is looking to insert itself into the cell, and the cell is what brings all the glucose into it, right? If this thing is covered up with a layer of fat, then the key has no place to go. This is what the number one issue is when we talk about obesity and type 2 diabetes. This is the reason a lot of people who lose weight, all of a sudden they're fine and they don't need to take medication anymore. It can also be a lack of insulin being produced by the pancreas. It can be a combination. But this is the number one driving cause. Again, chicken and the egg, obesity, decreased physical activity, right? And the problem, obviously, is society doesn't help any, right? You want to super duper size that? I got a lot of extra lard here I need to get rid of. Here's some extra French fries. Will you take it? Yeah. Give me a quarter and I can have a whole basket, right? 2/3 of type 2 diabetics, we're talking type 2 diabetics, 2/3 die right here. Heart attack related to hypertension, related to atherosclerosis. It's a real phenomenon. This is the major cause of these folks. Again, they don't die because their glucose level is 400. No, that's not what we're going to die from. Now, I was fortunate. When I was in school, we only had basically one class of type 2 oral medications that we had to learn. Glipuride and Diabeta, I think. Now, for my younger students, just so you know, we have 8 classes. And all I want to do is emphasize there's been a lot of research on this. And now there's a whole new focus on different causes. Again, metformin is still the number one agent you're going to see everybody has. Why? Because it will help to improve the sensitivity of this thing right here. That's the reason almost every type 2 diabetic is going to be on metformin first and foremost. And then you've got all these other agents, again, either trying to enhance, but the new thing now is, interestingly enough, in the pancreas, this bad boy, glucagon. A lot of it is focused on reducing glucagon. Because remember, what is the role of glucagon? To squeeze glucose out of the liver and put it back into the bloodstream to keep the brain happy and so forth. So now a lot of these agents are focused on reducing the influence of glucagon. That's what you see down at the bottom. Trulicity, Byetta, and so forth. How many of you folks actually watch some of these infomercials? Now, being a pharmacist, I have a tendency to, I've got a jaded view of these things, so I watch them, right? What's wrong with this picture is kind of what I see. But when you look at some of these new type 2 diabetic ads, you see a common theme? How many of those people in that commercial are underweight? How many of those people in that commercial are underage? Yes, there's a common theme. These are things that we can take control over in our lives. Got to be mindful of it. And also, let me also, again, this is the jaded me, but these commercials make it sound like, well, before I took this medication, I was poor and it feels so good. But I'm on this medication, and everything's fine. And it doesn't work that way, folks. It does not work that way. The commercials make it go from miserable to a sunshiny day. No. That's one small piece and a very big puzzle. Do not let those ads make you think, oh, if I simply take that medication, I can go to the Hog Trough Cafe and I can have a delightful time. No. And also let me emphasize, just because it's an oral medication, do not think it cannot cause harm and hypoglycemia. It can. It can, and it does. All right, some of the takeaways I really want to emphasize here. Education, education, education. When you're in front of a patient and they're dealing with diabetes, you need to help them understand it's a big issue. Lack of caring is not a good option. Careful monitoring is what they have to be mindful of. And you have to encourage, and you have to uplift, and you have to motivate them. My physical therapist in the room, I've got numerous studies. Any exercise is good exercise. Walking to the mailbox, walking to the end of the road and back is good exercise. Also, any weight reduction is good. A 5%, just a 5% reduction in weight can have significant improvements on type 2 diabetes. Right? And also for my therapist in the room, weight balance, let me rephrase that, weight imbalance is critical. You have to be mindful. There's a lot of damage to the key muscles throughout the entire body. And again, lack of physical exercise, lack of strength, there's a high risk of falls with these folks. Again, remind them about rotating the sites. Make sure they know signs and symptoms. And again, sometimes you have to put the fear of God in them. Let them know how serious this is. That's the only way my grandfather finally stopped smoking, when a nurse told him, you know, Mr. Davis, if you don't, he had emphysema, if you don't stop smoking, you're not going to see your grandchild, my older brother, grow up. He quit smoking because he now had a purpose. Sometimes that's what it takes. Speaking of smoking, no smoking in diabetics. Why? Because what does smoking do, right? It makes this freaking worse. It makes this freaking worse. It adds pressure. Part of the whole thing of smoking, it causes vasoconstriction. That's what gives you that, ooh, I feel like running a race, right? No, folks. No smoking in diabetics. They can't handle it. You're going to be busting these things even faster. Kid you not. All right. Here's some free information for you. Because as I've done this, and I know I'm getting short on time, but as I've done this, questions have come up, and I want to emphasize something. And for my RDs in the room, if you know the answer, don't shout it out. When we talk to patients about their diet and eating and so forth, we encourage them to eat what?
Low carb, high protein.
Why? What's the other word for it? Starches, right? Starches. What the hell's a starch, right? Well, this is what happens. In the body, in the blood, right? When you eat something, here's your stomach, here's your intestines, right? When you eat something, it gets absorbed. What comes across into the blood? Well, when we talk about carbohydrates, right? We've got monosaccharides that basically form all the other sugars. There are 3 monosaccharides, mono being one, the basic, right? Glucose, fructose, and galactose, right? These are the basic building blocks of carbohydrates. That's what they're broken down to. That's what goes to the blood. When you combine these, glucose, fructose makes what? Table sugar. It's called sucrose, right? It's just a combination. Glucose and glucose makes maltose, and glucose, galactose makes lactose. Excuse me, these two make lactose, right? So it's combination. So all of a sudden, these things begin to combine. If it's short chain, we call them an oligosaccharide. If it gets longer, we call it a starch. So the reason we want to emphasize patients to eat whole grains, complex carbohydrates, is because if you eat just sugar, it goes whoop right into the bloodstream, and the body's like, holy moly, what just happened? But if you eat a complex carbohydrate, it takes it time to break down, so little by little, it gets into the bloodstream. So the body's like, okay, I can handle this. I can deal with this a little at a time. I can deal with it. Foods have what we refer to as a glycemic index. That's simply an aid to help diabetics understand, if I eat this, my glucose level is going to do this. If I eat this, my glucose level is going to do this, right? So let me ask this question. If sugar, table sugar, has a glycemic index here, what common food that some of you already had today that we eat would have a glycemic index here? White bread. It's amazing. True story. My cousin, her daughter, is on an insulin pump. When she was, middle school, we go to a seafood restaurant, the family. And when you go to a seafood restaurant, what do they bring to the table? Hush puppies, right? Hush puppies. So she tests, I'll never forget this, because I'm sitting across from her. She tests her daughter to see what her glucose level is, to see how much she needs to bolus her with her pump before she eats her meal. 2 hush puppies into it, she retests it. It had already gone from about 180 to 400. All right? Because the body can't handle it. There we go. Now, one other quick thing, because if you read it on the internet, it must be true. You'll see God's gift to mankind and diabetics is something called what? Fructose. Where does that come from? Well, it comes from fruit. So it must be a good thing, right? Honey and blah, 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 and apples and pears and so forth, right? Here's the kicker. Yes, if you go to the store and you buy fructose because Glenn said glucose is bad for you, so I'm not going to eat any more glucose. I'm going to eat fructose because it sounds healthy, and I read it on the internet. Wrong. Here's another unfortunate metabolic complication. See, the body knows how to handle glucose, and glucose stimulates the production of insulin. Fructose, yes, if you consume predominantly fructose in your diet, no, your serum glucose level will not go up much. But guess what? Because there's a lack of insulin being produced because you're eating fructose, this becomes the new goo. All of a sudden, you've got a new problem of goo beginning to go into your circulatory system because there's not enough insulin to properly take care of this. So again, be very mindful what you eat, and don't get caught up in too many of these internet stories. Questions, thoughts?
I just had a question about this high blood sugar in the morning after low blood sugar at night.
The
So how do
homogeny
we know
phenomenon?
if that's happening?
Well, again, you're checking patients. They're going to have to check their glucose at night. If you really want to know what's happening, they're going to have to get up, around midnight or 2 a.m. and just do a test. If they're constantly having an event where they're okay in the day, but they're high at first thing in the morning, it needs to be checked. And that's when you'll find out.
So I was wondering if they ate a snack at bedtime, which we usually tell them to do,
Mhm.
which they don't do.
That should do it.
But if they did, then that would help that.
Absolutely.
So it should be lower in the morning if they consistently did that for a little while.
Correct. Because again, what you want to do, here's what it comes down to. This is what unfortunately happened with our patient that had that unfortunate event. If this is a balance, you've got glucose in and you got insulin, and you want it to be balanced. So if you start changing either one of these, then you have to adjust the other one. But it's simply a balance. So don't start changing your diet without changing your insulin, and vice versa. Excellent question. Other questions, thoughts?
It seems like though on the sick day information that you get like on, like the claims site, it says not to stop their medication if they're not eating or if they're sick, like sick day instructions. So,
Including insulin?
well, usually it's like oral, usually on orals, but
I think what you need to be mindful of is how long that's going to last. Because if it's a half a day, Mary Louise, you can chime in. If it's a half a day, okay, maybe. But if it's a day, 2 days, you got the flu and you're not eating for 3 or 4 days, I would not do it.
Even the orals.
Even the orals. Because they're going to work. They're going to take what little bit of glucose is in here and they're going to get rid of it. Other questions?
I think when it comes to sick day rules, our important thing for patients is to teach them, like short-term things is one thing to keep on your normal schedule, but when it does start lasting longer, they really need to contact their physician because their meds may react differently for them and others.
Correct.
And hopefully the physician has that in mind because, one size doesn't fit all.
Correct. Any other questions? Well, then I thank you very sincerely for being a wonderful audience, and I hope you were able to learn something and take to your patients. Thank you, everybody.